So Dr. Christensen, she's currently the Chief Medical Officer of Indian Health Services. So she'll be talking about the IHS and how she's bringing health equity to Native communities across the United States. Dr. Christensen, thank you for being here.
May I share my screen?
Yes.
Thank you. Okay, well, thank you all. I'm happy to be here. I saw a few colleagues in the participant list, so hello to all of them as well. So here's a nice picture of part of our reservation in Navajo where I was before moving to headquarters. And I always like to show this to everybody up front because it shows you just how vast this area is. It's so beautiful, but how vast it is and how far in between everything is. And which creates some of our health disparities and challenges that we face when delivering healthcare. So this is our mission. I'll only really speak to the beginning part, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. And of course, we want to build healthy communities. So just as an overview for those who are not as familiar with the Indian Health Service, we provide comprehensive health service delivery for 2.56 million American Indians and Alaska Natives, and we serve members of 574 federally recognized tribes. Our total staff hovers around 15,370, and then you can see the breakdown of our staff there. This is just a quick summary of how we function, and when you know, almost 62% of our healthcare system is tribally run via the self-determination PL 93-638. So where we have 24 hospitals, there are also an additional 22 on our tribal organizations. You could see that tribal 279 health centers. And then of course, a unique feature is our Alaska Village clinics, because we really don't have large clinics there, but we do have multiple village clinics that operate and provide really excellent care up there in Alaska. So I know everybody on these calls probably understands all of these definitions, but I just want to kind of set a foundation here to talk about what we do very well in Indian Health Service and what some of our challenges are. So health disparities, which I know was spoken about earlier, really looks at how it affects groups of people who have experienced systemically different obstacles to health. And it can be based on race or ethnic group, religion, socioeconomic status, gender, age, mental health, physical disability, sexual orientation or identification, and geographic location. As you saw from my picture of the Navajo reservation, it can be quite rural areas that we're talking about. And then health equity. This is what we'd all like. And as was said by the previous speaker, is that we want to get to a point where they say, when do you know health equity is better? I say when we don't have to ask that question all the time. We're just treating everybody the best that we can, giving them the same resources and the same commitment to support their health status across the country. But health equity is the principle underlying a commitment to reduce and eliminate disparities, very much so the social determinants of health. And we want the highest standard of care for everyone. So that would be my dream, and that's what we work towards. So I love this picture. I know many of you have seen it before, but I think it frames things very nicely for us. In the first image, it is assumed by giving everybody the same box to stand on that each one of them will be able to see the game. So they're being treated with equality or equally. So then we go to the next image and we kind of fixed it a little bit. We gave the person who wasn't able to see over the wall 2 boxes, and then the one that sort of could see 1, and then the tall person or that only needed a little bit was able to see without a box. So then we're being equitable. But the goal really is in our third image, when everyone can see the game, everyone can be in the game without any supports, because we have systemically addressed the barriers. We have addressed that structural racism that's being faced by many BIPOC communities, and particularly the American Indian and Alaska Native. So let's say, how did that factor into how we experience things in COVID-19? These can be extrapolated to non-COVID, but I think this is a great illustration. So important data on American Indians and Alaska Natives is missing. Either people weren't asked to identify their racial or ethnic identification, and say like me, we're more than one race, but we can only give you one. So if they picked American Indian, Alaska Native, we captured that data. And if it didn't, we might have missed it. And this becomes very important when we're looking at vaccination rates, why we might not have, I think our numbers are much higher, but we weren't able to pull data from outside the IHS jurisdiction to really verify that. And then initiatives that were put out, and they were put out with good faith. I want to say that up front, but they didn't really account for our American Indian and Alaska needs. For example, home test distribution. Well, those of us who grew up near or on reservations will tell you, we don't have addresses in many of our places on the reservations and tribal lands. So therefore, how could you order tests to be delivered if you don't have an address or you don't have a PO box that's readily accessible? So this didn't really account for those needs. And then more recently, when we looked at the test to treat that's rolling out right now, we didn't really take into consideration that we don't have commercial pharmacies where most of our healthcare clinics are, or our reservation lands are. We don't have long-term care facilities that received a lot of the tests to treat. And we didn't have federally qualified health centers, or not too many anyway. So where would we access this first push out of test to treat? Well, the answer of that is that IHS had to adopt its own test to treat, which we'll speak about in a moment. So what happens? There was switching between equality and equity. So when we were trying to get our allocation of therapeutics, we had pretty good contracts in place, and all the credit in the world to our National Supply Center, who have been exceptional. They got a hold of things. They got us contracts. We had access to everything: monoclonal antibodies, test kits, home test kits, course vaccines, and any of the other medications we needed, like the oral antivirals, we would get for our population, and we would have them for them to use to try to keep them healthy. But when that became scarce, when those supplies weren't the production wasn't keeping up with the supply, they began to allocate on a pro rata basis, which then switched us to equality and missed some of our equity issues, which I'm going to go through with our population. So this did change the way we had to respond. So let's look at this. This is actually not bad data, and I've been tracking this throughout COVID. And I'm going to tell you it's much better on this slide because I updated it this last week. So our cases are still 1.6 times more than everyone else. We were way over 2, by the way, as recently as a month ago, 2.2. Hospitalizations still have never dropped below 3. We've had 3.1 to 3.8 times more hospitalizations in our American Indian Alaska Native population. And our deaths are still 2.1 times everyone else. And that was also higher in the high 2s. So we're doing a little better right now, but still very poignant to look at these numbers of what we faced. Here's another depiction, and a little bit broader, and thanks to the Kaiser Foundation for all their excellent data during COVID. And you can see very clearly how we just really were hit so hard. And we knew this, most of us knew this would happen, but here it is in reality. So what is the impact of the disparities that have, I'm sure, been described on public health? Well, housing is important. We had multi-generational homes that were quite small. So we didn't have positive people, we had positive families. So we knew that was something we would have to deal with. We knew that transportation was an issue, as it always is on many reservations. And with gas prices as they are now, it is very hard to think people can get, quote unquote, into town or to the healthcare facility. Food insecurity, we have this all the time, but it became much worse during COVID because we're saying isolate, stay home, don't go out for 7 to 10 to 14 days, depending on the situation and when this occurred in the pandemic. People, one, can't afford 14 days for groceries for a full family. Second of all, in some areas like Great Plains and Navajo, there's less than 15 markets in 20,000 square miles of reservation. So where was everybody going to go? To the same stores, which wasn't good for social distancing. And and couldn't get what they needed a lot of the time. Thankfully, there were a lot of food distribution and great partners throughout the pandemic that helped us get food out to people instead of making them search for it. Access to healthcare, I think the Indian Health Service and our tribal organizations put their healthcare in places where the most people can get to them. But that still doesn't account for those very extreme rural areas, such as I showed you in that picture. How do we get care to those people, or how do they get into care? So many of them probably stayed safe they were so isolated to start with, they stayed isolated. But that isn't really the answer that we really want. Environmental hazards, for example, where I was in Navajo, I got asked a really good question the other day. Do you think the chronic exposure to uranium toxicity also made things worse on that particular Navajo Nation? And I said, yes, I do. I think constant toxic stress from uranium and heavy metal contamination, along with this super virus that we've been dealing with for over 2 years, did increase, and that gave Navajo one of the highest hit numbers for COVID. Despite all the excellent measures that were done there, we still got hit extremely hard. And then, of course, basic things that when you talk to other people in this country, when you tell them there's no running water, they honestly look at me blankly and they say, oh, come on. And I'm like, no, really, 30% plus on Navajo, I would say in Great Plains and some parts of Alaska, there are people, they don't have running water. And you're saying, wash your hands, great hand hygiene, make sure you do this, to keep your family safe. And we did give them mitigating ways to do that, but it wasn't easy. And then some don't even have electricity. So when you look at that, you look at, can they have an oxygen machine at home? Can they have nebulizers at home? And the answer is no, a lot of the time. So that would just be normal standard healthcare. And then, of course, the one sometimes people don't think about is access to broadband, because not only does it affect communication and getting the most current information, how do we do telehealth if we can't reliably get on broadband? Well, we did a lot of telephonic calls, and we're very thankful for the support for that. And we hope that will continue past the public health emergency. Very briefly, this is just a list of how, if you look at the leading causes of death, that we are a bit different from the other categories of Caucasian and Black and Hispanic. So we do struggle with different diseases, which is actually a whole lecture into itself, but just to give you a snapshot of that. So then what happens to us? Well, if everybody is stressed all the time, we have higher deaths from unintentional injury. There's a lot of, as we know, historical trauma there. There's a lot of things that trigger things that are very, very unpleasant. So we have higher numbers of substance abuse disorders, and we're having a very hard time right now kind of coming out of this pandemic, because that's gone way up, and we were making progress prior to that. We do have high rates of obesity, metabolic syndrome, and as was mentioned, diabetes. In some areas, not all, high tobacco use, but overall, as American Indians and Alaska Natives, it's pretty high. Higher suicide and mental health issues. This really spiked in several places and obviously was quite profound, and we were extremely worried about these areas having these suicide breakouts. And we try to send resources as soon as possible. And then again, lack of access to information. So let's see what actually really happened here. I have a few slides on this just to give you a visual on this. This is a really nice slide by CDC, which looks at confirmed COVID. Now, remember, a lot of our Native communities used those home test kits, and this kept them from having to travel. It allowed us to get more kits out there for testing, and then we hooked them up with public health. And then, so we're not counting those in here. So there's probably a bit more there. And it just shows clearly how many more cases there were and how many more hospitalizations there were that we had to deal with as a population. And then here again is a nice graphic that got all the way up through January. This is the weekly cases. And I think we finally started to fade a bit here, over here in January 22, which is good news. And then deaths, we just had this horrible time into December, January 2021, where we were losing, a lot of our people, our elders, and it was a very rough time for everybody. But you see we had some really good dips in this, and I think we had less peaks than the rest of the country, maybe one less peak. And then of course we got hit with the Omicron later on. So this is how we worked our jurisdiction. As you know, or may not know, all of the healthcare organizations could choose to get distributions through Indian Health Service or their state. So this just lists the ones that chose us. So that's why I say our jurisdiction, 355. We got data from them. We got the vaccines to them. We shipped out therapeutics, home test kits. We also, I'm very proud of our team, sent out over 8 million N95 masks across Indian country, giving people a stack for their family. We didn't have limits on that. We gave everybody at least 2 per person, and if needed more, and we got those out in less than 2 weeks. So again, a good job by our supply center. So this is who we served and still serve through COVID. This kind of tells you a breakdown of where our population is with our biggest areas, of course, and in Navajo is about 15%, and then we have Oklahoma, which is our biggest, and very many tribal organizations, as was talked about with a really nice presentation before about the residencies and all that really great development there in Oklahoma, which we're very, very proud of that as well. And then when you look at the positives, and despite, look, we did a great job testing, I think. You know, we really got out there. We knew it was important for us to keep our eye on it. And still, you know, we still couldn't really close that gap. So this is just by area how we did with testing compared to all races, which was around 8.4 and then 9.3. And then that again is a nice epi curve that gives us, you know, where we kind of got hit, and then we got hit again with the Omicron. So I like to always put things in a positive way. And the way I describe how Indian Health Service and tribal facilities that we serve, what we did well and what was very positive. And what is very positive to me is the people with the least sometimes do the best, because we rely on each other, we rely on community, we relied on an amazing workforce across Indian country that just have been amazing in taking care of others. One really important thing is we were able to advocate for allocations of vaccines thanks to all our tribal leaders. It shows when you speak up and you push and you just stay on it, we can make positive impact. So we had good allocation of vaccines. After that first shipment, which we know was limited for everyone, we have had ample vaccines and we have used them very well across Indian country. Our adaptations. So like I said, we created our own test to treat. We decided to go out across our jurisdictions and say, which one of you is ready to test and treat and can get protocols in store, and we'll get you the medicines. And we advocated with ASPR and IHS and everyone, we can do this. We have the people. Our people need to be treated. We don't want them in the hospital. We don't want them to get critically ill. And we have created, and this was done in 1 week, we created a test to treat for us in our jurisdictions. And then test kits, we have been shipping those out for over 1.5 years. We have widely used the home test kits for the Department of Corrections, for the schools. We supported the BIE schools, the off-reservation boarding schools, and we helped them all make sure they had screening and surveillance supplies. So this came together, again, creating our own equity. We made sure everybody got access to this. And then amazing community response. All of the applause and kudos go to the people across Indian country that stepped up, that got vaccinated, that got their boosters, that kept their families and communities safe. This was an amazing response. And when we look at our vaccine data, yes, we led very early, and we're very proud of that. And yeah, we've kind of leveled out, and we're still working on that. We will continue to work on it. But I think what is really important is our biggest push for vaccines was before Delta. And therefore, we headed off a lot of severe cases of COVID because we had a big part of the population vaccinated very early. So we were ready, we were waiting, and we responded extremely well. I also give a good shout out to our tribal leadership, public health orders, closing the borders, keeping on masks longer. shutting down unnecessary businesses. The tribal leaders were key and critical to preserving the health of all of our people, and I'm very grateful to all of them. And what we really focused on a lot, of course, is protecting our elders, which is our history. And we worked very hard, and that is a huge high percentage of our vaccinated are 65 and over. So again, did an amazing job working together. So here is the last graph of this that CDC put out. And we did really well. We were on top for a very long time. We've leveled out now. And so we're retooling and looking for new ways to get to our younger age groups to make sure those 5 through 11 and the 12 through 16 are taken care of, so they can do sports, so they can get back together, so we can keep our kids in school. So what can we do? Well, we continue to always advocate for equity. We're there on the table saying, this is what we need, this is why we need it, and we need this to take care of our population. Secondly, we have to really work on our sustainable infrastructure, because you can't even work towards health equity unless you have a sustainable infrastructure. That means getting those watering access sites in those reservations that don't have running water, making sure that we have, facilities that are safe and that take into account climate change and severe weather, so we can have that infrastructure that goes on from generation to generation. Improve our transportation. What innovative ways can we get people to appointments or get us to the people? And that's our next bullet, mobile healthcare access. In these extreme rural areas, this is very imperative that we think of other ways to get to people, because the chances of them driving that far as often as we would like to see them in our facilities is not high, unfortunately. So it's incumbent upon us to keep working together with our communities and finding ways to do that. Innovation for provision of healthcare. How do we get through on telehealth? How do we do all those things and optimize them? How do we do partnerships with academic institutions? Right now, one of our main objectives at headquarters is to hook up with cancer centers so that we have a referral place that we work with that understand our population, who are culturally appropriate and sensitive to our needs. And also will be available then for the telehealth follow-ups. We're also looking for long COVID centers right now for those specialties we don't have in Indian country, but we can get our population to. We got to expand our education and training for public health jobs, as well as us looking for nurses and providers and pharmacists and lab clinical scientists. We have to look at those public health jobs. In Navajo, we were so fortunate. We had some really excellent epidemiologists. They weren't hired under those titles, but they were amazing and stepped up, and to this day do a fantastic job. And I'm sure that is very true in a lot of our communities. There's hidden gems there that we're able to repurpose and use. But how about let's educate our tribal communities in public health, surveillance, tracking, investigation, and epidemiology. Partnering with external resources. We have a lot of agencies in the government. Are we all helping each other? Are we all connected to each other? Are we communicating? And I think we could do better. And we really, I know I reach out a lot with NIH and the studies they do, and USDA, who has great food access programs and food sovereignty. And we want to start all working together and using each other's resources for the betterment of this population. And of course, healthy food access. There are ways out there. We just haven't connected all the dots together to get food as medicine to our people. And then we have to continuously enhance preventative care. Don't let them get sick. Don't let their health status not be optimal. Let's get them what they need to prevent this. This is community cancer testing. This is, just really getting our, we have a new program, health coach program at headquarters. Our first class is starting. And these are going to be lifestyle health coaches out there helping our people exercise, make sure they're eating right, teaching them right there on the spot how to live a healthier life, and to use our ways to look at our wellness models in each of our community and incorporate that into our care. And I'm going to wrap up by saying the most important thing I could say today is my thanks and deepest gratitude to all the heroes across Indian country for their tireless work during this pandemic. You never met more amazing bunch of people that have weathered this pandemic and taking care of each other so well. So my greatest thanks to them. I love this quote. We see a time of 7 generations when all colors of mankind will gather under the sacred tree of life, and the whole earth will become one circle again. And that is what equity is. It is one continuous, supportive circle of care and community and connection and love and compassion. So thank you so much for the opportunity to talk a bit about what we do. And thank you so much. Okay.
Thank you, Dr. Kushkin, for that excellent talk. So I did have a few questions. And so I had a question about health equity. So, you know, I know you showed the picture of the boxes and kind of redistributing the boxes. So how does that work in practice? I think that's something that Mass General Brigham is thinking about, is how we redistribute the boxes. And so I was just wondering what you thought about that.
Well, that's a great question. And if it was so easy as boxes, I would be very happy. But I think what it is it is setting that expectation that you're looking at every population you serve, and you have to know where they are. Like I said, some of the things that I'm sure were very well intentioned, and I have faith in that, didn't look at the fact that to reach certain populations, what you would have to do to put that box there. Well, you know, if you don't have addresses, what would be your next choice how to get things to people? Well, I would ask the people that know those regions and work through those and say, hey, we need your insight into this so we get this right, so we get this to everybody. But you know, that thought is that we're so looking at the big picture, sometimes we're not looking at what holds up that big picture. You know, if it's people can't get a ride to an appointment in the city sometimes either, so it's not just the rural areas. But I think largely, you know, any program that looks at diversity has to look at rural America. You know, with probably 40% of healthcare delivered in the rural setting, what does that mean? Yeah, there's not health clubs for people to go to and work out. So what can we do? Well, we make trails. We have a program called Just Move It, where we have these walks and these runs, and it gets people moving and out there. And then you can teach them about health and wellness when they're there. And so you have to, you can't just have one way of doing things. I think you have to look at the basis for each population you serve and say, how do I serve that population in an equitable way? And what do I have to do to get to where's that box? What boxes do I need to do that?
Right, right. And then also you talked about collaborating with academic institutions, especially for cancer referral. So have there been a lot of barriers to making these collaborations?
I think that, you know, I've had really good reception from all the academic institutions. I think our challenge is fear. It's historical trauma. It's the cultural appropriateness and sensitivity, not because the doctors aren't very kind, I don't mean that, but they don't understand the population. Like, you can't say to certain tribal members, and each tribe is different, you have cancer. That's like you gave it to them. Mm-hmm. So instead you have to say, well, this might happen if somebody has this, and you're going to say the same thing, but it's the way you interact with that person, whether they're going to come back. So you have to have that conduit, that navigator, which we also are very much in favor of, to be that advocate for that patient and make sure that the communication is in one that that person understands. And as I put it before, you can't stay in a granite building and do this. You got to get it out into the communities and become part of the community. And you know, I'll give a shout out to Johns Hopkins. They do this very well. They're in our tribal communities. They're respected. They help us. They're with us. So when they go and say, hey, let's do this clinical trial and let me go over it with you, they have a much better chance of connecting with that tribal leader in those communities. Plus, they use local community members to work a lot of their programs. So there's trust. And we know a lot of it's trust, you know, with unfortunately the boarding schools and all those trust issues, the trauma-informed care becomes extremely imperative when dealing with our American Indian and Alaska Native populations and our staff.
Right. Yeah, and then also Dr. Dab has talked about a program where she sends people from Mass General Brigham out to various Native sites, and then also they're sending residents out there. So how do you encourage physicians to join Indian Health Services?
You know, I think I loved Dr. Bray's talk on the residencies, and this is one of our initiatives right now as well. We do have a rural residency at an IHS facility starting up in northern Navajo, which is in Shiprock, New Mexico. And what that allows us to do, we have lots of students that rotate, and we're very grateful for that. That is our opportunity to integrate them into our communities for that brief time and really show them what that service means, how much help it is to have knowledgeable and good doctors come out and help. And just that immersion, I think, is very crucial to swaying people to look at rural medicine as a career. It's not for everybody, and certainly the challenges are profound because they are very, very rural areas. But I will say, though, on the balance of that, the counterbalance to that is that we have people that were in the Indian Health Service for a very long time. So when they stay, they really stay. And so they're very dedicated to our populations. We're very grateful for that. And then I'm going to tell you, I worked in private sector for quite a long time at a pretty big center. And I never did the surgery there that I did in the brief time I did surgery in Gallup. I've never seen pathology and cases like that in a very long career of how sick people are, and they still walk around and do everything they're supposed to do. And so it is an incredible, enriching opportunity to see what disease does when there is lack of, there are disparities, there are all these challenges that our population faces, and they learn so much when they go back into private sector. Those that leave, they are profoundly trained. They have pretty much seen everything. And I think that enriches them as humans as well. But we're so lucky, we do recruit a lot of people through rotations and residencies and students coming to see us.
Well, very good to hear that. Well, Dr. Christensen, thank you so much for joining us. We appreciate all the work you do at IHS.
Thank you. Thanks so much for having me.
Yeah, thank you.